Warm welcome to the 38th webinar of Pediatric Orthopaedic Society of India. I'm glad to say that today Indian Orthopaedic Association, a giant organization of 13,000 orthopedic surgeons of India, we are also joining this program together. So the topic of today's program is current concept in the management of open fractures in children. We are really fortunate to have 5 international faculty: Fergal Monsell from United Kingdom, Arnold Besselaar from Netherlands, Shital Parikh from USA, and Vikas, Gupta and Venkatadass from India. I will give a brief introduction about our panelists. The Fergal Monsell is an orthopedic surgeon at Royal Hospital for Children in Bristol. He is director of A1 Center for Musculoskeletal Education, and he is editor of Paediatric, a wonderful website which gives information about the decision making in various types of fracture in children. His main area of interest is deformity correction, infection, and trauma. The second expert is from Netherlands, and I am really happy to say that he is coming to POSI platform for the first time. Welcome, Arnold. Arnold is practicing at Maxima Medical Center in Netherlands, Southern Netherlands. He is director of the Dutch Pediatric AO Trauma course, and he is faculty at AO Pediatric course at Davos for more than 10 years. The third person, Shital Parikh, very well known in India. He is faculty at AO Pediatric Cincinnati Children's Hospital. His main area of interest is medicine and trauma. He has a keen interest in sports medicine, and he has authored a book, Patellar Instability, and he has also edited a book on the pediatric anterior cruciate ligament. So I welcome Shital also. The 2 Indian faculty, Dr. Vikas Gupta, practices at the Safdarjung Hospital, a famous hospital in New Delhi, and his area of interests are deformity correction and clubfoot. The 5th panelist is Venkatadass. He practices at Ganga Hospital in Coimbatore. He is also executive committee member of POSI, and he is popular for the last physical conference which we had in 2020. He has published Ganga Hospital Open Injury Severity Score, and this is going to be one interesting topic for the discussion today. Just to give you the format of the webinar, this webinar will be based on the case discussion. So we are going to give basic information about a case, and then we are going to have opinion of our panelists. And from the discussion, we are going to learn. And with each case, we will present what the literature says. So this will be more of experience-based and supported by evidence also. If you have any question, and I'm sure that you are going to have a lot of questions, please WhatsApp your question to the WhatsApp number of Dr. Sandeep. That's 98230-63989. Or you can WhatsApp to Dr. Navin Thakkar, the Secretary of Indian Orthopaedic Association, 98253-87016. I repeat, 98253-87016. Before I hand over to Fergal, just a brief introduction about upcoming webinars. We have a very outside the box webinar on the 13th of May, Thursday, and that's about a topic, improving the patient's satisfaction. We all work to satisfy our patient, and how to maximize the improvement or the satisfaction of the patient. That's going to be the theme of that session. And we are really fortunate to have our author and the TEDx speaker, Dr. Helen Race. She is a psychologist and psychiatrist at Harvard Medical School, and she has written a book on the empathy effect, a very popular book on the topic. So this is going to be a very interesting topic for everyone. And then we have a core pediatric topic on the 19th May, that is recent advances in the management of upper extremity problems. Again, we have a faculty from experts from USA, Scott Koshi, Kevin Little, and then Zrotlo. They are going to be the faculty for the program. So with this, I hand over to Fergal Monsell for the further proceedings. Thank you. Over to you, Fergal.
So that's it. Thanks, Dhiren. It's a very, very great privilege to be involved in a POSI webinar. It's my just great hope that I'll be able to come to India again very soon to join you in person. We'll just get started with this. The format we're going to go for is we're going to look at cases, each of which will bring out particular points from the panel. But in general, the first two cases will be using the Ganga score to try and predict what optimum management is for limbs that are at the extreme of salvage. And the question really, salvage versus amputation, working through the cases without the panel knowing the outcome necessarily to see what they would have done and how they're influenced both by their experience and by the scoring. Case 3, it really involves a case which salvage isn't in doubt, but there is a very significant bone loss component. And that will bring out a discussion for options of reconstruction of the bone component. And then the fourth case is when there's massive soft tissue loss, not necessarily a major fracture problem, but a big soft tissue reconstruction problem, and then the options for reconstruction. We've got other cases, I'll just go back, we've got other cases following that depending on time, and they will bring out other specific points, but the main purpose of this webinar is to detail these 4 cases, and anything else time, and they will bring out that to be a bonus. And so first case is this patient, is a 14-year-old male, road traffic accident, 2-wheeler versus a 4-wheeler. And you can see, I'm just going to run through these. We will go through them in some detail in a minute, but I just want to contrast the first 2 cases that we're going to deal with. And so as you can see, there's a very significant full thickness degloving injury on the lower part of the tibia, soft tissue. But skeletally, there's a segmental tibial fracture. There's a complete displacement of a physeal fracture of the femur. And that contrasts with, if I can find my buttons, that contrasts with another case, which it's superficially quite similar, is there's major soft tissue loss, there's a tibial fracture, there's a distal femoral fracture. And so both of those cases have got great similarities, but fundamental differences in the approach. And Venkat, the question really is salvage or amputation. And first of all, the question for the panel and for the audience is in both of these 2 cases, just looking at them with the information that you've got, which isn't very much, what your thoughts would be about the likelihood of successful salvage and the benefits of early amputation. So I'll throw that out as a question, and I'll leave just some time for thought on that.
Okay, so let's have the first opinion. Shital, would you like to start with the first case? Like, what will you do? Will you go for the salvage or you will go for the open amputation straight away?
Yeah, no, I would prefer salvage for most of the open fractures, even if there is significant score on whatever score we use, and for a few reasons. One is that the pediatric literature is not very strong when it comes to using these scores. They are mainly meant for adult population. All the validated scores, which is mainly the mangled extremity score, it's meant for adults. When these scores were used in children, and there are a couple of articles, Kurt Graham from Australia has published that none of these scores were validated for kids, for children. So for a 15-year-old, you can make an argument that he's nearing skeletal maturity. Maybe you can use an adult pattern of score, but certainly for an 8-year-old, you can't use a score that is only meant for adults. Having said that, I would prefer to use salvage just because kids have higher potential of healing. The periosteum is thicker. The debridement needs to be kept to minimum compared to adults, where you want to debride as much as you can. Here, the principle is a little bit different. So as a first attempt, I would try to salvage, these cases. I would, do a debridement to make sure they get their timely antibiotic and tetanus. That's the first thing to do. Do a provisional fixation, because debridement, stabilization, and coverage are the principles that we need to follow. And, no matter pediatrics or adults, debridement, stabilization, and coverage. So I would go with that route, but I would definitely try to salvage both of them.
Okay, so like the Shital believes that like for both the cases, he will go for the salvage. Let's have the opinion of Vikas. What do you think? Will you, in your institute, there are a lot of patients, lot of workload. So will you try to cut down the workload by going for the amputation straight away, or you will go for the salvage first?
Thank you, Dhiren. Definitely, I'll support what Shital has said. Definitely, I'll go for the salvage. And in India, we all know that amputation carries a social stigma. And that's a very big issue. And moreover, as he has said earlier, that scoring actually may not actually predict the need for amputation, especially in children. And I've seen cases where scoring, the Ganga score was more than 17, but they could be salvage. It has been shown also in the Venkat's paper. So my first priority will always be a salvage, but definitely you have to counsel the parents for delayed amputation if required. So I think my first push would be to salvage the limb as much as possible.
Okay, Arnold, what do you think? Like in Netherlands, would you like to go for your patients? Like, do they accept amputation with reluctance, or like you like to go for the salvage, as what Shital said and Dr. Vikas said?
I think that they are being said very wise things. There is no such a strong stigma on amputation in Europe as with you, but nevertheless, in children, especially when children are 8 years old, then you will go very far as a doctor to save this limb. On the other hand, I think that it's very important to inform the patients in a very early stage that if the problems are too big, that you very early tell the parents that there's possibility of amputation. And I totally agree with the things that have been said. My first attempt definitely would be to a salvage. But I can't say enough that it's so important to talk with the parents about the severity of this injury.
Okay, so like we have a three opinion which is strongly suggesting to go for the salvage. Now let me add on to the complexity of the situation. Suppose there is a vascular injury. In that case, I would like to ask you, like, are you going to change your decision making, or still you say that you will continue with the same thing? And then the next question, again parallel with the same question. According to you, what are the clear-cut indications for amputation in the first setting? So both questions. If there is a vascular injury, will your management protocol will change? And the second, according to you, what are the clear-cut guidelines for amputation on the day one? So let's start with that. Shital, what do you think about that?
That does increase the complexity. So then this would be a 3C if there is a vascular injury. And the thing is that things have changed. See, in the last, these scores have been all dated, prior to 2000. And, some of these scoring systems have recent validation. But at that time, the microvascular surgical processes were not as technically, not as advanced as we have now. We have, great team. And that's the other thing is that probably if you're in a center where you don't have too much support, then these patients need to be shipped because, we are really fortunate. We have vascular surgeon, we have plastic surgeon. So, we depend a lot on them. I can't deal with all these. I can just, do the washout and I can do my bony work. But I depend a lot on my plastic surgeon colleagues, on my vascular colleagues. So to have a 3C is not an indication to straight go for an amputation because they can do microvascular surgery as needed, depending on the level. Having said that, the absolute indication would be a near amputation, like, it's a crush injury with everything that's out, nerves are out, vessel is out, your compartments, all the muscular tendinous junctions are out, then yes, that's a primary amputation. You can't, and that is different from someone who has a clean injury from a machine or something, then you can replant, So there are, differences in the mechanism of, how the injury has occurred. Just having a vascular injury would not be an indication for an amputation.
Fergal, what do you think? Agree with 100% what Shital said, or like your practices in UK is different than what Shital said?
I think I completely agree. You can't underestimate the benefit we have of working with immediate access to plastic surgery, immediate access to vascular surgery. It makes a difference to what you can reconstruct. So in our practice, the default is to preserve the limb. And it's only if you run into difficulties with that. And I think you make a very good point. When you've got a complete or near complete traumatic amputation from a crush injury with the nerves gone, the vessels gone, you have to really be honest with, and that is a limb that is very likely to be amputated. Now, it doesn't have to come off straight away. And there is a very big argument. And the most recent one we had in the last couple of months was an upper limb ripped, too much traumatic amputation, and it was probably overambitious to salvage it. But the 3 or 4 days that between tidying it up, second look and making a decision made a massive difference to the family. And whether that's legitimate or not, I don't know, but it's anecdotal, and it made a difference to their processing what was in front of them. It didn't sort of they had an opportunity to ask questions, look for options. But there are some cases, and I think you've described it perfectly, if the limb has just been crushed, rolled off, there's nothing left, that's really, that's already, that's beyond what we can salvage. But anything else that's, take the nerves out of the question, everything else is reconstructable usually. The nerves make the biggest difference to me.
Okay. Yes, Arnold, what do you think? Your practice is the same like what Shital and the Fergal said, or it's different?
Well, especially that nerve and vessel. I would have a very low threshold to make an angio in a very early stage in this kind of, especially in the first case, because you have to be good informed about those vascularity. And nerve problems, I think, are very devastating. But I totally agree. We have the same measurement, and I also, if you have I've also as a doctor, it's quite hard in a child to do directly an amputation. So if possible, then you start in for a salvage. But if you see nerve and severe vessel damage, of course, we try to debate with our vascular surgeon and our plastic surgeons as quick as possible to make a decision together. And it can be that I say, well, I think it's salvable, but that the vascular surgeon or the plastic surgeon say, no, this is too damaged, it's too crushed. We have to decide otherwise.
Okay, then there is a counter question I would like to ask to Dr. Vikas. Fine, let's put neurovascular injury at present aside. At what soft tissue level you would consider that this is not salvageable and you would like to go for amputation? So do you have any idea about at what level of soft tissue injury you would like to go for amputation? Or you believe that you will go for plastic surgery at later date, whatever may be the soft tissue component? Yes.
Yeah, working in a tertiary center hospital, we have the advantage of having plastic surgeon and vascular surgeon 24/7. So, like I said earlier, even if a vascular injury is there, we have the vascular surgeon to evaluate the case. And your question, what kind of soft tissue injury, almost like a dangling limb with crushed distal part, would be an indication for the primary amputation. But in majority of cases, if we could see that neurovascular is intact, distal circulation is there, and we would like to have the plastic surgical consult. And most of the cases, we avoid doing primary amputation unless either the case is coming late with already gangrenous limb, where we have no other choice, or it's like a dangling. So definitely I would try to save the limb. That's the first priority in our institution.
Okay. So, Venkat, would you like to ask any question related to that? Because you have done a wonderful study on this. So, would you like to ask any question to the faculty?
No, I completely agree with the fact that we try to salvage as much as possible when it comes to open injuries in children. But only thing is, in our practice, compared to what Shital and Fergal are seeing, what we face in day-to-day challenges, the first thing is, what, as Dr. Vikas correctly pointed out, the time of arrival. So the injury arrival delay, when they come in the borderline of say 6 hours or later, then we have a question of whether to go for a major revascularization or go ahead and amputate. So injury arrival interval, because our setup is as such that patients coming from about 200 kilometers radius, they take a lot of time to arrive to the center. That is the one thing which we need to take into consideration. The second thing is affordability, because unlike their setup where insurance takes care of everything, our patients, most of the patients pay from their pocket. So ours is a private institution, and then that also comes into not a major play, I would say, but then that also has to be taken into consideration when we are venturing salvage or a major reconstruction, which needs multiple stage surgeries over a period of 6 to 8 months. So that also needs to be considered in our practice.
Okay, yeah. So that's
another very hard for salvage. Yeah.
Yeah, so that's the another practical dimension to the problem. Like reaching to the hospital takes a long time in India because we don't have the ambulance service that good. And the cost, particularly in a private hospital, also has to be taken into consideration. So good. So we have a wide opinion about this. So let's go further and see what happened to the case. Yeah. Further.
Okay, so this is case one. I think, Venkat, this is do you want to talk through this case? I can run the slides if you want to just talk through it.
Sure. See, this is a 15-year-old boy who presented to us less than 4 hours of the injury. So he was traveling in a two-wheeler and was hit by a four-wheeler and was run over actually in the lower limb. He did not have any other injury. This is a typical scenario which we get in our country: two-wheeler versus four-wheeler and an isolated limb injury, unlike polytrauma, which you see more in the Western system. And because of the bleeding, he had hypovolemic shock on arrival. Can you move on to the next slide? And you're seeing the wounds here, and you can see that there is a major crush injury of the lower part of the leg, and posteriorly all the muscles are hanging out. And you can also see that there is a small puncture wound in the proximal third, middle third junction. So whenever we see a wound like this, so what we call it as zone of injury has to be assessed. So whenever the dictum is if there are two different wounds in the same limb, so it is for sure that there is a degloving unless proved otherwise. So the skin in between is having hypovascularity or it is dysvascular, and it can go in for necrosis in the days to come. So we should be aware of the fact that while assessing the limb, we need to take into consideration that when we see two different wounds in the same limb, so there could be degloving. There is degloving unless proved otherwise. And you can see that there is a segmental fracture in the proximal tibia as well as extending into the distal third of the tibia, and there is a physeal separation of the distal femur. And there was contamination with muck and mud in the distal wound. This is how he presented to the casualty, and he was having hypotension. Dr. Vikas.
Yes.
How would you proceed on this? So if you want to salvage, is there anything else?
Yeah, the principle of management remains the same, like ABC. And we have to first go for medical stabilization. You told me he's having hypotension. So IV access, and the priority would be starting antibiotics immediately. And our protocol also includes tetanus prophylaxis, irrespective of the status, which actually is not known in majority of the cases. And definitely I'll splint the limb, and definitely we'll go for early irrigation and debridement, get the OT time. But the first priority always remains to stabilize the child, and without even going for the radiography.
All right. So he was not that unstable like a polytrauma child. It is a monomelic injury. just to the right lower limb. So we took X-rays and then wheeled him into the operating room. Can you move to the next slide? Fergal, you want to add on something?
Can I just ask what the vascularity of the foot was like at presentation, and where was the blood loss from? Was it clear?
I did not get you. So the blood loss,
was the foot perfused? I mean, they've lost a lot of blood. Is there an obvious arterial injury, or is this just a lot of blood loss from the open soft tissue?
There was no active bleeding when he came. So there was injury to the vessel, the posterior tibial, but it was not bleeding actively when he was received in the emergency room.
Okay. And so this is for this, do you want to I'll go through the scoring? Venkat, do you want to score it and I'll go through the slides?
Do you want to tell the score of this particular patient or score in general, or how
if we do each component of the score?
Yeah. So the Ganga Hospital open injury severity score was developed based on the experience of treating a large number of open injuries over many years. The score was initially published in 2004 JBJ's British volume, and it was mainly described for adult open injuries. And if you look at the score, basically it was designed for scoring type 3B injuries to decide between salvage and amputation. So whenever it comes to type 3B injuries, the other scores which were existing at those times, the MES score, the NISA score, all those were for type 3C injuries where you have a vascular injury. So if you don't have a vascular injury, then the MES score and NISA score, everything will come very less. So and when you go ahead and try to salvage those patients, if it is a bad 3B injury, you may have delayed amputation or secondary amputations. So that is the reason why we came out with the score. Rajashekharan was the author of the score initially. And it has four components. One is skin, we call it the skin score. The second one is musculotendinous unit score, and the third is bone score. So we score each and every component of the limb separately. And added on to this, we do the co-morbidity score, which is taking the general condition of the patient, which includes right from age and the associated injuries, like if you have a chest injury or a head injury, or if there is an associated injury, major injury to the same limb, or if you have a contamination, hypotension on arrival, injury debridement intervals. So all these things are considered as comorbidities, and we give 2 points to each. So if you look at the scoring system for each score, the skin has 5 scores. It is an increasing gradation. So skin score of 1 and 2 essentially means that there is no skin loss. And 3 and 4 is there is skin loss, and the score of 5 is a circumferential loss of skin all around the limb. So if you look at it simply, score of 1 and 2 can be easily managed. So you don't need any special skills to manage a skin score of 1 and 2. As the score increases, beyond 3, you need either a plastic surgery like procedure like a skin grafting, or a flap or a free flap. So that is how it was graded. Similarly, in musculotendinous units, so as you go along the score, as the score increases, the complexity of the injury increases. And in bone as well, as the same principle is applied. The score 1 in bone is a simple transverse fracture or a oblique fracture. And score 2 is a comminuted fracture. Bone score of 3 is a segmental fracture. And bone score of 4 is a fracture with bone loss of less than 4 centimeter, and 5 is more than 5 centimeters of bone loss. So that is how the scoring was designed. So for this particular patient, if you go ahead and score, so you'll have a skin score of, and we have to note that the scoring is usually done at the end of debridement preferably. And there is skin loss over the fracture site. And hence this will get a score of 4. And if you look at the bone score, there is a segmental fracture, which is segmental open fracture, gets a score of 3 right away. And if you look at the musculotendinous unit score, so there is loss of one compartment posteriorly, so it gets a score of 4. And if you look at the comorbidity, there was severe contamination, and he was having hypotension, and there is associated major fracture in the same limb, so it adds up on to 6. And the total score runs to 17 for him, which is like peri-amputation threshold. So we need to have a lot of caution before trying to salvage this limb, and that is exactly what do you want to know at the end of the scoring. So there is a one another paper on the philosophy of management of open injuries based on the Ganga Hospital severity scoring. So wherein we retrospectively analyzed all the patients and found that less than 10, a score of less than 10, you can, most of the times will be able to get away with a single stage fixation and a fix and flap protocol. So if the score is more than 10 to 14, you will most likely need a stage reconstruction, and anything more than 14, this is for adults actually, between 14 and 17 is a gray zone where you need a lot of teamwork and multiple stage reconstruction to successfully salvage. As far as children are concerned, the numbers were very less. We had about 52 children only. So we were not able to give any strong conclusions, but whatever analysis, from the analysis, we found that anything more than 17, you should be really careful and counsel the parents that they might end up in a secondary amputation later on. Up to 17 was the cutoff value based on the analysis of those 52 children. So this was, as Dr. Vikas told, this was taken up for debridement and external fixation. And this is the picture after debridement, and he had a free flap done for the defect on day 4. I think he had a anterolateral thigh flap.
Should we just go around the panel and see what the opinions are for immediate management?
I'll just like to ask a question to Venkat before we proceed. A few things. One is that this patient you said had a posterior tibial arterial injury, so that becomes a 3C. So is your classification is meant for 3B? It can be extended, and if you extend it, then how does the scoring change? That's my one question. My second question is your muscular tenderness score of 4. I may not agree with that. If you say that there is complete loss of the entire compartment, I think that there is still tendons I can see, and there is still maybe some functioning muscular tenderness units. In short, what I'm saying is that I completely agree with the scoring pattern. I think it's great for the setting that you are in, and you have much more experience than what we do. But having this scoring system validated by other institutions would be preferred, so that we can all either learn or see how you score it, because I can't score it the same way as you.
Scores can be the same for 2 different surgeons when you have a major injury like this. So there will be a difference of 1 or 2 in each of the component, but overall, if you look, it does not make a much of difference when it comes to overall management. That's what we found. So as you said, muscular tendinous unit, if you score this one as 3, between 3 and 4, it does not make a major difference. We scored this as 4 because the posterior compartment, the superficial compartment was completely gone. The tendo-Achilles was cut. So, and for the first question regarding the vascular injury, 3C, 3C, if we take it as 3C only if the limb is completely ischemic. Now, when you have an anterior tibial artery which is good, intact, the circulation of the distal the part of the limb is maintained. So you can, we don't take it as 3C actually, and we don't, you can extend the scoring for 3C also. There is no harm. So because as you said that the microvascular techniques are advanced now, and when you do a revascularization, your 3C directly becomes a 3B. Yeah.
Can I ask, I was concerned about the displacement of the distal femoral fracture with the distal segmental injury. I was worried about the popliteal artery and vessels. Did you do anything about it? Did you do an angio, or did you explore, or just assume that they were okay because there was distal runoff?
No, the anterior tibial circulation was good, so we did not do any angio.
Okay.
So the anterior tibial was picked up on Doppler. The handheld Doppler, the circulation was good, the toe circulation was good. So angio was not done, and it is not there in our protocol to do an angio for these major injuries, usually.
There's one thing I wanted to say, Shital, you said about being less aggressive with the soft tissues in kids. Can I explore that a bit?
Less aggressive with the soft tissues.
That was
I think Shital's suggestion that, yeah.
Shital, can I explore that a bit? I've got a...
Yes.
Sure.
because my view is you know where one of the areas we fail is by underestimating the zone of injury and leaving tissue that's necrotic or will become necrotic. And so for me, I'm as aggressive with the soft tissues in a kid as with an adult. It's dead, it's dead. The bone's different. The bone, I agree, the biology of the bone is slightly more forgiving, but I think sometimes the soft tissues, particularly if you're going to do a soft tissue transfer, if you transplant onto a dead tissue base, it's going to fail. I mean, I'm very lucky. I'm speaking on behalf of my plastic surgery colleagues, but this is what they would say and they really, they take a surprising amount of soft tissue away when they're doing their debridement.
Yeah, so, I mean, I would be very conservative in children because at the initial, I'm talking about the initial debridement, because we may think that things are dead and things may not vascularize, but kids have amazing potential to revascularize. So what I was talking about is let the tissues declare themselves. So on your second debridement, when you go in, yes, anything that's devitalized, necrotic, you're going to remove it. But don't just assume because it's just there is no tissue underneath that there's a flap, you would excise it because there is no vascularity. I would wait, not just jump into a wide debridement on kids. I would wait and let the tissues declare themselves, and within a few days, within 2 or 3 days, you would know what is necrotic and what is dead. But not on my first debridement. I'll be conservative.
I don't have any difficulty with that. I completely agree with you. Yeah, it's at the time of soft tissue reconstruction. You've got to be absolutely clear. Then I agree. You don't have to be very aggressive.
I want to ask the panelist, what is the role of VAC? How often do you use VAC in these kinds of wounds?
We would use it on all patients. Like this patient would get a VAC. So on all patients with soft tissue loss. So any skin loss, muscle loss, we'll use a VAC on them. So till they are ready for coverage. So that's what we'll do. And
I agree with that.
Day one VAC, or you will wait for the relook?
No, day one, right from the beginning. That's what we do, is use VAC right away.
I completely agree with that. And the thing about VACs as well is if you take them from the medical device company, they cost a fortune. But if you get an aquarium pump, some cling film, you can make your own VAC, and some foam. You can make a very, very cheap VAC. You do not have to have all the funky, sophisticated stuff that they'll charge you hundreds of dollars for. That's just a point that I've learned from traveling, that you can make them out of what's lying around.
Even VAC reduces the need for free flaps in some of the cases.
Yeah. I think it's very important, and I think we use it very. Dhiren, sorry.
Yeah, Shital, there is a question for you about the debridement. Like, say, how do you decide the extent of debridement? And you said that you would like to be conservative in children compared to adults. So can you clarify more on that, because audience wants to know about that? What is the difference?
So I would not extend. So say, for example, it's, I'm talking about grade 3, bigger wounds. If it's a small puncture wound, there you're going to make a small surgical, expansion, and you're going to then debride the end. But when you're talking about debriding a big wound like this, I would not take away whatever is necrotic on day one, like it's devitalized, it's hanging, you're going to trim it. You don't want to push it in. But I would not take away skin and not take away muscles and tissues, because they could regain some would be just spasm. Some of it, even if it's not vascular, it can revascularize in children. They have great healing potential. I'm talking about skin and soft tissues. So what I'm saying is that the first day, you don't need to extend it too much and cut off and remove everything that's, that you think is dead. You can give it a chance. You can take off things that are already, not attached to anything, and all the debris and everything. But in 2 or 3 days, when you go for your second debridement, which is typically 48 hours, you go for a second debridement, you'll get a chance to then debride it. So, our goal is to get coverage in 7 days. So you're going to have a couple of 2 or 3 debridements before that. So, I would just do it stage-wise rather than jump into it. The other thing with the VAC, a lot of things, that we may think that, it's a big gap and big wound, is things would start to granulate, and they can, and it would decrease your space. So being conservative does help, because you may think that this would need something, and it may just be a primary closure. So I would not debride it just, based on my initial assessment. I would wait and let it, declare itself.
So
Venkat, please.
Yeah, so being conservative in debridement is a good idea, as Shital told, but I would like to stress the point that in our country, all the open injuries which we see has a lot of mud. So removing dead tissue or suspected avascular or dysvascular tissues is one part of it, but we should make sure that we remove all the mud and muck out of the wound. If you see the debridement which we have done for this patient, we always remove the tendon sheath, which has mud. There is no way you will be able to clean the tendon off the mud without removing the tendon sheath. So that's what happens.
That brings a good point about your geographic location. You see, everyone is everywhere. It's going to be different. It's based on what you see. Same with the antibiotics. It's based on local. What you see the most is what your antibiotics are going to be on. You just can't say that this is the best antibiotics. The same thing with, if you're seeing more contaminated wounds, which we don't see it that often, so you have more experience. Yeah. Then I would agree that, you need to just make sure that you remove all the debris, I'm sure that, in UK and in Netherlands, they may have similar principles, but a little bit different protocol. Your principles are the same. You want to remove all the dirt and all the dead tissue, but the way you approach it may be based on the location where you practice.
Quick questions here for all panelists. How much solution will you use, and what solution for irrigation? Shital?
We use plain water.
Normal saline.
Normal
saline 3 liters per grade. So 1 grade is 3 liters and 2 grade is 6, and then 3 grade is 9. It's just like a rough estimate, but around
Fergal?
6 to 9 liters.
Normal saline with a pulse lavage.
Pulse lavage. Do you feel that will contaminate it further, pushing the dirt in?
I think it's a good point, but we'll do a debridement, a sort of a visual debridement, and then I'll use a pulse lavage until it's clean. And sometimes 3 liters a minimum.
Sometimes the bone is stuck in mud, and then there is intramedullary muck. How do you remove that?
I'll take a window out of the. Are you asking me?
Yeah. Anybody could take that.
Yeah, I mean, if there's obvious visible contamination, I'll make a window in the bone on the end of the from the fracture proximally or distally, to cut a channel in it so I can see the medullary canal, just as I would if I was doing an infection. It doesn't usually happen, but if you've got dirt under pressure up the medullary canal, you've just got to clean it out. So the only way I know to do it without contaminating it further is by making a window.
Okay. Anything different in Netherlands? Anand?
Yes. Okay, so go ahead.
Well, I do not like the pulse lavage. So, Fergal, thank you very much. So I wash it out just with my hands with a sponge, and I try not to damage the soft tissue with the pulse lavage.
Okay.
And I very much would like to add in this discussion that I would estimate that not the message must not be to be very conservative, but to think otherwise, because it are kids. So you're so right. When you talk about crush, when you talk about contamination, then I would suggest to be just aggressive. But if you have ruled out that, then I'm totally agree with Shital to work on that protocol.
Okay, Shital?
Yeah, Sandeep, that's a great point about the mud, in the medullary canal, because, in a type 3 where everything is open, it's very easy to see where the mud is. But I'm more concerned about that, in a type 1 fracture, when you only have a poke hole. And the most important question you need to ask is, what was the surface that you had a fall on, whether it was an organic surface or whether it was a clean surface. Because I have seen that, the spike of the bone can come and take a biopsy of the ground and go back in.
Yeah.
All right. And
especially farm injuries.
Yeah, that is where it's, it looks like a grade 1. And, that is where you want to make sure that you deliver the bone out of the wound, make a bigger incision. And so you don't know that until you ask them the surface. And you won't see any contamination on the top. But it's a very important point, because that's where you would get in trouble.
Thank you, Shital. So I think, Venkat, we'll move on here.
Yeah.
So
So this is, Venkat, do you want to just talk through the outcome?
Yeah, so on day 15, the foot became ischemic and he landed up in a BK amputation. So this was an attempted salvage, but moved on to amputation. Regarding the debridement, I just wanted to add on that these injuries are called burst lacerations. Whenever you have a high velocity injury, the energy is transmitted to the limb and then they all burst from outside, the energy comes out. So when we have any open injury around the joint, we have seen that it sucks in the mud. So it is very important that you open the joint completely, and then you will see a lot of mud inside the joint pouches. So it is one of the points which we need to remember when we are doing a debridement of an open injury near to a joint, particularly in a high velocity injury. Yeah.
Good, Venkat.
Next slide.
Can I ask about the level that you chose to amputate? Was there, if I go back a slide, again, you've got, that's quite a short segment. And is there any merit in trying to conserve the segmental fracture with some soft tissue to try and make it a longer amputation?
No, but the soft tissue was not good enough. So this was...
you said the foot was ischemic.
The foot was ischemic, but then if you look at the injury wound, there was degloving.
It's not a criticism, it's a question. Let me just, there we are there. That's when it's been cleaned up. And so is that all dead?
This whole skin has we cannot say that this is going to survive, but I don't remember this case. This was done long back. And the decision for amputation is usually, so in our institution, the debridement is done along with the plastic surgeons. So we do the debridement.
So just one question to everybody here. Who takes the decision for amputation? Is it one person, you, the primary treating orthopod, or with plastic, or with vascular, or more than two people? Do you have a panel? What should be the policy?
Ours is a combined approach.
Yeah, it's combined with the plastic.
Yeah.
Okay, so we agree upon that.
Combined.
Okay, go ahead.
Can I ask a question? Yeah, is anyone taking cultures, pre-debridement or post-debridement cultures in these kind of wounds?
We gave up on a long time back.
Yeah, there is no role. We want to convey to the audience.
We did a study, but it did not give any meaningful conclusion. So we stopped doing it.
So when you did the amputation, this patient is 15, but if it's a younger kid, then the number one complication that we have seen with an amputation is overgrowth, the stump overgrowth. So any recommended tips, like for this patient, what could you do to prevent overgrowth?
Well, first of all, I would do anything to have as much as soft tissue coverage, the bulkiest you can have, to have into account that overgrowth. And there are all kinds of things you can try to make a connection between tibia and fibula. You can but if the kid is young, my experience is that the overgrowth is a very difficult thing to handle.
So what do you do, Shital?
You take the epiphysis and jam it. That is one way of doing it. So from your amputated part of it, you take the epiphysis, whether it's a talus or the end of the tibia, and then you make a cartilage cap with a stump, and you just jam it in the canal. But you're right, you'll get a fibular overgrowth. The fibula needs to be cut shorter than the tibia. This is what we have experienced with amputation, not just traumatic amputations, but amputations for deformities. When they're congenital things, and you can do there are other procedures where you try to fuse the fibula to the tibia. And in one of my patients who had a very similar level had a farm equipment injury from a tractor. She was young and she had an overgrowth. The first time I did it, I took down the fibula and I put the fibula in the tibia. And I was concerned about the the laxity or the lateral collateral ligament insufficiency. So I kind of took down the periosteum and reattached it to the tibia, so you don't have a valgus laxity at the knee joint. But that worked, taking down the fibula, because fibula overgrows quite a bit. So taking down the fibula and reversing it and shoving it into the tibia gives me a cartilage cap at the end, and then I don't have to deal with the fibula. So that has worked for me at this level.
Right.
I agree with that. I think that's a really good way of doing it. It solves a lot of problems. I think what you mustn't do in the growing child is try and create a synostosis, because that will lead to deformity. And there's a lot of
The other thing is it's not the fascial growth that is giving you overgrowth. So don't try and do an epiphysiodesis. I would rather like the child to grow. So your amputation stump is going to keep on growing with the kid. It's an appositional growth. It's not a growth from your physis. So you need to just control it. Don't, I would be really, I would give that the message that don't try to do an epiphysiodesis because there was overgrowth.
I mean, we need to move on the next case.
Okay, your next case. So the summary for this is, because we've discussed the early management options, we talked about the indications for amputation, and I think the group consensus is in kids, it's salvage unless there's very specific reasons for it. We looked at the role of the score and the relevance for the high scoring limbs. And I think the consensus is, even in kids, that because of the biological plasticity, you probably will get away with things you wouldn't dream of in an adult. Again, technical considerations for amputation, some points, just tips and tricks. So the second case is similar. It was the one we showed at the very beginning. She was an 8-year-old on a farm, and her father was in a tractor, and she was crushed between the tractor trailer and a wall in a farmyard. So she arrived with it's an isolated limb injury, but with very significant contamination. And so our geography is favourable. We'll get these kids within probably 4 to 6 hours. Her skeletal injuries were, she had a tibial fracture, she had a femoral fracture, and she had a femoral condyle, a Hoffer fracture. So that was 3. She had no neurological or vascular injury, but she had a major, it's almost a circumferential degloving. There was space between the skin survived, but that was degloved on top of it. She'd lost most of her gastrocs. Her tibial nerve was intact, and she had a good pulse in her foot. Now, I don't use it routinely, but for the purposes of this discussion, I scored her using the parameters in the paper, and I scored her at 16. So again, it's the same sort of discussion. It's a sort of that salvage versus amputation score. And if we could just run through the options, a strategy from the panel for the management of the bone, management of the soft tissue. Dhiren, do you want to lead that?
Yes. So, like Shital, how would you manage soft tissues in this difficult case?
Once you have done a debridement, I would put a vac on, but based on the amount of skin locking is how would I, fix this, whether I want to use a temporary X-fix and then use an intramedullary nail versus, just use an X-fix as a definitive, fixation. And those are because here for the soft tissue, I'm pretty sure that needs a coverage, and the coverage should be in the first 5 to 7 days. That would be ideal.
Okay, Arnold, what will be your preference?
I agree, but this is, I think, a very good example. If you look to this wound, the wound edges are crushed and have to be removed. I think this here has to be done a severe debridement. I would wash it out with a sponge and very severe look if there's nothing left. And then I would also stabilize it with an external fixator. And then look further. You have to do a quick stabilization, not take too long operation time in the first attempt, and then think about it. I think the secondary stabilization of the bone is not so very important, but you have to give this soft tissues the possibility to revitalize and to be evaluated well.
Yes, Venkat, what will you do in this case? Please unmute yourself.
Sorry, I forgot to unmute myself. Yeah. So yes, debridement and external fixation will be the initial plan, and looks like there could be a vessel injury also for this child.
There wasn't, surprisingly, but there wasn't.
Okay.
Okay, so let's move further and see what happened to this patient.
Okay. So I mean,
so no one would go for amputation, primary amputation in this patient, right? Everyone agrees. Dr. Vikas, amputation?
No amputation.
No amputation. Arnold, no amputation. So no one is like going for amputation to this patient, right? Okay, so let's see further.
So initially, I completely agree. We put a monolateral between femur and distal tibia to just stabilize it. It had a debridement with plastic surgery and orthopedic surgery together. And the plan was to do a free flap within 2 days. We try and get them done within 2 or 3 days. So we set up for a free flap, and we based our management of the bone injuries on that. So do you want me to tell you what we did, or what other? Well, I'll tell you what we. The Hoffer fracture was the easiest Hoffer fracture you'll ever fix. It was wide open in front of you. You just needed a couple of screws. But what I wanted to do was I wanted to stabilize the soft tissues for the plastic surgeons, stabilize the femoral fracture, but knowing that that's likely to heal quickly. It's an undisplaced metaphyseal and a Hoffer, and then have the tibial fixator that I could then deconnect and have the knee moving as soon as I could. So we sort of set it up as a strategic fixator, initially to manage all fractures, but then subsequently to just manage the tibia. And what we do is I build these things around whichever plastic surgeon I'm working with, and you can if you use a ring fix, it doesn't have to be a hexapod. An Ilizarov fixator is perfect for this. And if you have a ring fixator that you can remove, so you can have access to soft tissues, then the plastic surgeons can work. So we just managed it like that, with a couple of pins into the distal femur, and the rest was done with an X-fix. Again, I agree. I don't think it matters how you fix the skeleton. It's really how you fix the soft tissues. And it was a scapular free flap with a skin graft that was done there.
Fergal, can I ask you something? What was the timing of this procedure?
Timing in terms of following the injury, or how long did it take?
What did you initially this?
No. Sorry, Arnold. Initially, this was a monolateral, just to stabilize it. 2-pin in the femoral diaphysis, 2-pin in the distal tibia, with a just to literally to splint the limb. And plastic surgeons did debridement, and then at 2 or 3 days we combined again to do this definitive procedure. I completely agree with you. To do a big reconstruction immediately is not sensible. You need to have a much more controlled environment to do that. So I think initially, I agree with everyone said the same thing. It's just a very rapid stabilizing external fixator. You don't need X-ray. You just need to put the pins in, put a bar across it. A radical or debridement of everything that's obviously dead, and then a second look. In our team, the plastic surgeons are quite aggressive initially. I can't speak for them, but it seems to work. But they want to have a clean at the time they do their soft tissue reconstruction. And we usually try and do it within 72 hours.
Just quick, Venkat, do you agree with this, or would you do something different at Ganga Hospital?
No, just the same. Only thing is we don't use ring fixators. We use the regular external fixators. That works well for us. Yeah.
Shital, what will be your, are you happy with what was done, or would you like to do something different?
Well, the initial stabilization with an X-fix and debridement and then a flap, I agree, but I don't use the ring fixator. I would have just put 2 nails, in the bone, especially if there was no bone loss. I would just come from the lateral side and just put 2 nails. So one, it's easy for managing, like pin tracks as well as the soft tissue and everything. If I have, so I usually don't like to use X-Fix as definitive fixation for these fractures, unless I have to, unless there is significant soft tissue trauma.
Vikas, what is your take?
No, the initial management remains the same. The trans-knee fixator to stabilize the soft tissues, and then we involve the plastic surgeons for flap or the VAC. But I use Elizero quite frequently as a definite.
And Sandeep, any questions from audience?
Yeah, not from audience, but I wanted a comment from all the people on the panel about primary internal fixation using nails, because nobody has spoken about that after debridement. Would you do elastic nails primarily? Any of you?
He'll do it.
In this kind of,
Because conventional wisdom is external fixator. But for us, if the fracture pattern allows, can we use elastic nails, and what's the opinion?
If the soft tissue is enough to cover the bone ends, that means they're not visible, implants are not visible, I don't mind doing an internal fixation. If the patient is stable, number one, that means that you don't want to increase your operative time. If the patient is stable, this is an isolated injury. There is enough soft tissue coverage that my nails would not be exposed. So I've got bone ends that would touch. I don't mind putting the nails in as a first treatment. I don't need to do an X-Fix. Here, probably, I would do an X-Fix because, probably the Hoffa, unless, as you said, the Hoffa fragment is easily visible, you'll be fixing it. It's just that the first time you're doing it, you don't want to, go too long, on your surgery. You don't know what's going to happen to the soft tissue part, so it's better to wait a few days. But if everything is clean, like not in this case, but otherwise, if everything is clean and the wound is big, might need coverage, but it's enough that it's stabilizing, that means it's covering the fracture, then I don't mind using a nail primarily without an X-Fix.
Right. So what would you do with the femoral fracture?
I don't think there is any other way of fixing it. I mean, you can use K-wires, but your screw is the best fixation for the Hoffa.
There's a femoral shaft fracture as well.
I didn't see it on the X-ray.
Sorry, it's on the CT scan. There's
on the post-op.
So if it's a floating knee like this, I would initially use the X-Fix like we did. But when I come back to do definitive fixation, I can see it now. I can see the fracture line on this X-ray here. So with the Hoffa, probably sliding a plate or something would be my preference, because it looks like it's pretty well aligned and less displaced on the initial X-ray as well. So maybe just getting a couple of screws in the distally would be sufficient. I don't think I need like a rigid fixation here.
Arnold?
Yeah, I agree. I like that idea of the submuscular plate. Then you can move the knee, then you have there access to the soft tissues, and I think the fracture is feasible to put a plate on. I would in the lower limb, I would be very, if you have such a soft tissue problem, I wouldn't choose for a definite fixation very easily. I would use a fixator.
Yeah, I agree.
Go on, Dhiren.
Yeah. Shall we go ahead for the next lecture, next case?
Yeah. Well, I mean, she, interestingly, her only problem now is with overgrowth. So we're following her up, and she's a bit long because of her overgrowth. But now the next case. So indications for salvage, some comparisons, technical considerations we talk about. I think it doesn't matter how you fix it; it's whatever you're comfortable with. I think that was borne out very, very clearly. And the management of the soft tissues, that's up to the plastic surgeons, but with a flap. I think we've done this, Dhiren. I think we have talked about this. We can talk about it a little bit more. Or should we just go on to the next two cases?
Yes, we go to the next cases. Yes.
Okay, so Venkat, this is yours as well. Do you want to talk this one?
Yeah, sure. This is again a 12-year-old boy who came with a type 3 fracture of the right leg. This is a fracture with a bone loss. Can you go to the X-ray? So we don't have the pre-debridement picture as such. Can you go to the next slide, please? So this is the picture after debridement.
Yes, so we have now two problems. The one is how to manage bone loss, and the second, at the same time, how to manage the soft tissue. So let's start with Vikas. What will be your strategy?
The first priority would be to manage the soft tissues, to cover the bone. And like a case like this is, I think the best choice would be an Elizero, where you can use the principle of destruction osteogenesis to cover the bone gap.
Right, but Elizero will make the soft tissue management very difficult. So will you prefer the Elizero in primary setting?
Not in primary. Like I would like to have the wound covered first by my plastic surgeon colleague.
Right.
We can use a temporary X-fix. And once the wound is covered, I'll prefer to go for Elizero.
Okay, so first is like the X-fix, then you go for the soft tissue cover, and then Elizero for the bone transport or some other strategy. Okay, Arnold, what will be your way of managing this patient?
Well, I think this is debrided very well. So that's the first thing. And I would like to shorten this leg initially, and to get a good coverage, to get a bone healing, and later on lengthen the limb.
Okay, so you have a different strategy. Fergal, what will be your management?
I bone transport or acute shortening. In this one, I think I'd probably acutely shorten it. I'd use an X-fix. You can build an Elizero with the front open so the plastic surgeons can get on it. You sort of do your temporary, most of your fixation using harpins. You unclamp it so they can get in, and then you close it back up. So I'd build a frame, I'd shorten it acutely, but build a frame for transporting. I'd wait until the bone ends had healed, and then I'd do a corticotomy and lengthen it as one procedure, provided the soft tissues let me do that.
Okay, so Shital, what will be your management protocol? There are two things, like different opinions. So what will be your opinion?
No, initially I would agree with, we'll vac it, put an X-fix on the first day when we do it, and then get the soft tissue coverage. There is a piece of bone that, it looks like it is devitalized, and that has to go, that middle piece. I would, just maintain the length till the soft tissues and everything heal, and then go with the bone transport. But I mean, the other way of secondary reconstruction with, acute docking now and then later lengthening it would be an okay treatment. But the thing that I think we should not do here is get into that area of soft tissue skin loss and where there is minimum vascularity of the bone, right, where there is. So what I'm coming at is that, probably doing something directly on this. I would like to stay away from this area, once covered. I would not like to go in that area, either to do bone graft or anything like that, fixation-wise as well. So I try to stay away from it because this, to me, it looks like there is no periosteum. There is gap, there is decreased vascularity, there is wound problem, skin problem. So try to stay away from this area once it's covered.
Yes, Sandeep first, and then over to you, Venkat. Yeah, Sandeep.
Yeah, just a question to everybody, because the IOA members are here, the adult guys, they have this masculate technique. Now, would you put antibiotic impregnated bone cement in such effects and graft it later after a flap or something? What's your opinion for that in kids?
I think that's a great option. I was going to say that, my partners have done it. I have not personally done it for these open fractures. It's a great idea. I think it works really well, especially in children, because they have, they can form good periosteum. Here, there is a lot of periosteal stripping. But if you can put a bone cement and make induced membrane and then come back and do bone graft, that's a good technique. As I said, I don't have personal experience doing it, but my partners here have done it, and they have. We just had a discussion about it yesterday for a case, and those who have done it, they say that it works really well. So
you can use an elastic nail and make sort of a candle and put some cement there, stabilize it also, and then put a flap on it.
Yeah, and we don't even need a nail. We just have to put a cement. It's like basically a dead space management. In that case, you just pack in cement, you maintain the length, and then we have done a couple of cases recently also. It works well.
All right.
Yeah, it does work well.
So let's move further, like what was done in this case.
So I would just come back to the case and have a difference of opinion. So two things. One, for acute docking. So we usually prefer to do acute docking of shortening up to 4 centimeters of length, particularly when we are thinking that we are going to avoid a major soft tissue reconstruction in terms of a flap. So it is like converting 3B to 3A. So when you are able to get a primary skin closure, if you are going to dock it, then it's worthwhile doing acute docking and then a primary closure, particularly in adults. As far as children are concerned, we have seen that spontaneous regeneration happens of the bone. Even if the part of the periosteum is intact, when you pull them to tension, pull them to length and maintain the length, we do see that spontaneous bone regeneration does happen in children. And they all do very well. So I would be little concerned of doing acute shortening as far as children are concerned. So for this particular child, that middle piece was removed and we pulled the bone to length and put on an external fixator, and he had a free flap done.
I generally agree with that, but what I think happens is, because of the periosteum being very thick, is when you lose bone, you basically got a periosteal sleeve that's behind, and that's what regenerates. In that, I'd just be concerned that you'd lost a lot of that periosteum, and although it may happen, it's not as reliable. If you've got all you need is a flimsy tube of periosteum, and it will do it for you. But that bone, it looks like there's been an awful lot of periosteum removed there.
So yeah, even as on date, even if there is no periosteum, we prefer to do the masculate. Put on a bone cement there and then get back later on for a grafting. Yeah, that would be our protocol. Preferred protocol.
I suppose it depends on which religion you follow.
Yeah.
Yeah. So let's move further.
If you want to Fergal, and if you want to shorten this for this particular case, you will have to cut the fibula as well. It's a green thickening of the fibula.
Yeah.
Okay.
Yeah, I know. Absolutely. Yeah. Or you can just bayonet it. You can shotgun it.
So Venkat, I think I agree with you on this shortening part of it. That I would do the same thing what you have done, because it's significant. After you've taken out the bone piece and debridement, that's a significant gap there. So I would do bone transport later on, but not do acute docking.
Is anyone putting PMMA beads in these gaps?
What beads?
Antibiotic beads, PMMA beads, which we use in adults.
No, it is stimulant. What you are talking?
Yeah, kind of stimulant. Yeah.
No, we can. The antibiotic impregnated cement beads. We have used it for really bad infection, but not in a primary setting of bone loss. But say, for example, this does get infected, then that would be the thing to do, would be to use local antibiotic beads with cement. But I have, there is, people have done it. People have used antibiotic beads locally and in an acute fracture setting. But we use it for infection, not for not for an acute fracture setting.
Use only if there is infection we use it. So not for open injury.
Go ahead, Venkat.
Yeah, this is on day 3 when he had a free latissimus flap. Go ahead, next slide, please. So he's having a gap here, and you can see that the spontaneous bone regeneration, which I was talking about, you can see that there is a sleeve of bone forming on the lateral aspect here. And we have many cases where there is a good bone regeneration. We did not have to do any secondary procedure as well. So for this particular patient, when there is a good periosteal bone formation, what would you do, Shital, at this point, at 3 months?
Now I would, if everything looks good, your soft tissue and everything looks good, I would do a bone transport.
Transport it.
Yeah.
Dr. Vikas?
Yeah, I'll go for bone transport. I don't expect this periosteal sleeve to completely reform the tibia.
Any role for grafting?
Like anyone would like to say for the fibula grafting in this?
Sandeep, you have...
I have good experience with gaps with non-vascularized fibula. But looking at this newborn formation, if you just put cancellous graft also, I think it will just heal up.
And just grafting, or you want to change over to a plate?
No, if the flap has settled nicely, you can plate and graft. That should take care of it.
Like
Same
cancerous
sitting
graft
or
Same
from
sitting.
iliac crest graft?
Iliac crest, yes.
Can I ask?
I think there is a natural periosteal tube which has been formed there, which is throwing bone. So you just need to fill that tube and stabilize it
How would you stabilize it? Would you use a
with a plate.
Can I just ask how people are people concerned about switching ex-fix to infix after a 3-month period, particularly seeing as there's obvious osteolysis on that pin there?
Yeah.
There's some I mean, at 3 months, is that a worry?
If there's no deep infection, I think a lock plate should do the trick.
No, but like, are you not worried about the infection at the pin track?
No, but 3 months, if there's no discharge and it's healed at 3 months with a good flap, you could give a small 8-day interval of for pin tracks to heal if you want.
But how can it not be infected? I mean, I regard all my ex-fix pins are infected by the time the kid leaves the hospital. They might not be discharging, but they're colonized. So at 3 months, I'd just be concerned. I'm terribly paranoid about this.
I guess Indians are used to be colonized.
Sandeep, I'm Irish.
Yeah. No, I do agree with Fergal's concern. I would be concerned about pin track. Converting from an ex-fix to a plate.
Yeah. So what will be your strategy, Shital, in that case?
Bone transport, as I said. I won't.
Okay, bone transport. No infix.
No.
Okay.
Okay, Venkat?
Yeah.
So we pretty much routinely do conversion of ex-fix to infix without much problem, as long as the pin tract is looking healthy and there is no active discharge, it's not red. And we haven't faced major problems. Of course, there are a couple of cases which gets infected and where we had to go ahead and remove the plate again and convert to bone transport. It does happen, but it is, I would say that it is not a bad idea. It does work well in majority of the cases.
Venkat, in the same sitting, or do you give a gap a few days?
No, we can't give a gap. So for conversion for ex-fix into nailing and bone grafting or plating, usually we give a gap of 3 weeks minimum. So, but for this case, if you remove the fixator and then give a gap, there is a chance that you may lose alignment, collapse, and all that things can happen. But yeah, for anything more than 3 months, we usually remove the fixator and give a gap of 3 weeks at least before conversion to.
And what would you use for bone graft, Venkat? What would you use to bone graft the gap?
Iliac crest.
Cancellous graft or no, or any structural graft?
Cancellous graft.
Okay. Right.
And go
So
ahead.
if the gap is huge, then we use a fibula.
Mm-hmm.
So here you use the fibula, right?
This is not fibula.
Okay. So it is iliac crest graft.
Yeah,
It looks structural. Okay. All right. You use a tricortical. Okay.
To
Great.
move on, and then at 2 months after grafting, 5 months after injury, we're there. And I've just moved that forward. At 9 months since injury, we're there. We are a little bit short for time, so I'm just going to run through this. At that point, developed an
Infection
abscess in
was
the
there,
leg.
and then yeah.
Can I just go back to that? Where was that a pin site, or was that just superficial collection?
Superficial collection.
Okay. And when you say did you just take the flap down to get onto it, or?
No, but the skin was. I didn't get your question.
No. How did you manage the flap to get to the infection?
No, it is for covering the wound again.
Okay.
So because of the infection, there was skin loss again because of the abscess. So they had to do a cover.
Okay.
And Venkat, when you did the plate, what was the approach?
Lateral.
2-3 flap.
No, the flap was on the medial side because if you look at the wound, it was on the medial side. So this was on the lateral side.
Okay.
And did you open it up completely?
Pardon me?
Did you open
it was
it up?
open. You have to open for plating, right? And bone grafting.
Mm-hmm.
So without opening the fracture site, we can't put the graft inside.
So we'll go to, and then at 2 years.
Venkat, how do you compare this with bone transport in terms of period of time of healing and complication?
Almost the same. Bone transport is definitely the complication of infection is not there. But then the time of healing is going to be almost the same, I think.
And the weight bearing would be better using a circular frame vis-a-vis internal fixation.
Yeah, because we don't do Elizarov. We always use a monolateral frame. Or even for transport, we use LRS, the monolateral frame. And with plate also, we allow them to weight bear and walk.
Okay. So this is just for you. This is not a very common scenario. Most of the time, because you have vast experience. So I just want to know, most of the patients that you treated this way would not have any issues, would not have infection. They would heal and they would do fine, right?
Yeah.
Okay. Good to know, because I've not done this, conversion to a plate with bone graft on any of my patients that I remember.
Yeah, for adults, we use nails actually, nailing and bone grafting.
Yeah, no, that we have done. That is fine. But, to go into that area, the zone of injury, back through the flap or around the flap, and then put a plate on, that's kind of a little bit scary because, I'm concerned that in cases of infection, I might just lose my soft tissue.
Shital, actually, compared to nailing, plating is better. If you have to induce an infection, it's going to be intramedullary infection across the whole length of the nail. So if you're doing a nailing and bone grafting, that would be actually a disaster if it gets infected.
That's true. Yeah, if you're converting an X fix to a nail, you're correct. That would be a disaster.
There is a question from audience, like why did you keep your fixator for 3 months?
3 months, I don't remember. Most of the times the delay will be from the patient side. They will not come for review.
Okay, but given a choice, would you like to go in for internal fixation?
Usually 6 weeks we start.
6 weeks.
Yeah.
Right. Okay. Right. So, any other question Shital, would you like to comment anything related to that or the lesson which you learned from this case? What you will do and what you will not do?
So one thing is, in pediatrics, the tibia fracture still behaves a little bit like the adults, but that's not the case for every open fracture. So I would, not take this and apply it to other bones. Say for example, forearm open fractures or femur open fractures, they behave a little bit differently. All our problems are with tibia, obviously, because that's the commonest open fracture that we see. But, we are in the last, and I would say last 15, 20 years, intramedullary nailing, like the flexible nailing for pediatrics, has been a big, has seen a lot of, advantages, for open fractures. So we use it all the time. It's not too much out in the literature just because, as I said, it's in the last 15, 20 years. So all the papers that we are reading about open fractures and about your scoring systems and everything are a little bit outdated, I would say. So, with the newer advances, internal fixation techniques, making sure you have a plastic surgeon friend that you can rely on, with the microvascular advancement and with the VAC and everything, I think our results are much better than what they used to be in the past. So that is my message. That I would consider using X-Fix initially, but flexible nails have helped us a lot with long bone fractures in children, open fractures as well.
Okay. Before I hand over to Sandeep, please, Venkat. Yeah.
So Shital's comment is a very, very valid points out of their experience, but I would like to caution that about the regional difference in the injury and the kind of contamination we see, and we should be more cautious before using an internal fixation primarily for open injuries, particularly the flexible nails for open tibia fractures. With the kind of contamination, if it's going to get infected, we are going to burn the bridges. So that is one thing I would like to caution. And as far as upper limb injuries are concerned, we primarily fix all of them with plates. There is no problem of infection. But as far as open tibia fractures are considered, I think X-Fix still remains as the workhorse for us. And we don't want to take a chance because I don't see any added advantage of using an intramedullary flexible nail in terms of duration for healing, particularly in those major injuries which is going to need a flap and which is going to take time for it to at least 3 to 4 weeks for the flap to settle down. So I think it is important to understand that we need to play safe as far as our injuries are concerned.
Okay, so thank you very much, all the faculty. Now I request Sandeep to say vote of thanks and the summary of the session. Over to you, Sandeep.
Thank you, Dhiren bhai. So at the outset, let me first welcome Harold and Dr. Navin Thakkar from IOA who have joined us today. Harold, welcome to the POSI family. I'm sure Dhiren bhai and all of us are going to keep you busy in the recent future. Fergal and Shital, thank you very much for sparing your time. You are always part of POSI and have contributed immensely. The Indian faculty, Dr. Vikas and Venkat, and finally OrthoTV for, as usual, making this a very good seamless presentation. To summarize the session, I think it suffices to say that children's compound fractures are more forgiving than adult fractures. You can get away with a little less debridement, less aggression, and they are more conducive to better healing as compared to adults. However, the basic principles of debridement and temporary stabilization using fixators seem to be the consensus and safer than trying to go in for primary internal fixation. But as Venkat has pointed out, contamination varies with region. Urban contamination versus sports injuries contamination versus farmland injury contamination. So it's important that you must customize treatment depending on your situation. And secondly, if you are in doubt regarding the viability of the limb, even though Ganga score is meant for adults, it's a useful score which can help you classify in which spectrum are you lying. If you're in a rural background or a rural setup with no plastic surgeon, it's best that you clean it up and pass it on to a higher center rather than trying to fiddle around with a doubtful viability limb. Ganga score can definitely help you make that decision. So it would be worthwhile to follow a system of classification or scoring which will be validated eventually if more and more people use it, even in children. So I think POSI can take up that as a study also, whether we can validate that for children, and eventually develop a team of a plastic and a vascular surgeon along with you so that you can have shared decision making and shared responsibility for counseling the parents regarding salvage versus amputation. And always warn them that there will be need for secondary procedures like bone grafting or removal of implant or lengthening or bone transport in the future when you're dealing with open and compound fractures. With those few words, I think I shall bid everybody good night and stay safe again in the second and the third wave that's come up. Thank you very much.
Thank you, Sandeep.
Thank you.
Bye. Bye, everybody.
Goodbye. Thank you.
Good night.
Ashok, recording. Okay, fine. Good. Recording is